Dr. Jason Liauw. I work primarily out of Mission and Mission Laguna Beach Hospital, but I also go to Saddleback as well as Hoag Orthopedic Institute. So I'm pretty much cover most of Southern Orange County. I'm part of the Orange County Neurosurgical Associates, which is a lot of words for we're just a big neurosurgery group in South County. And just a little bit about me. I'm actually from the area. So I actually grew up in Mission Viejo. I opted to come home, and that was probably the best decision I ever made. I went to Capistrano Valley High School, and then from there went to the Midwest. I went to Washington University in St. Louis. And then I went to medical school up north in Northern California at Stanford University. And there's a picture of Stanford there. And definitely a lot of my heart is in Stanford. It's a really gorgeous place, a lot of fun. And then I decided to go out to the East Coast for probably some of the more rigorous training at Johns Hopkins Hospital. So Johns Hopkins is the #1 neurosurgery program. Probably at that time when I joined, it was a #1 hospital. I don't know if it still is, but it was for about 21 years. And it's a kind of a mega house. So there's just a lot of surgery, a lot of procedures. This is a picture of the new hospital when it was being built at Hopkins, and that's in Baltimore and Maryland. Over there, I had the opportunity to just do lots of training, lots of good, I was there for 7 years, and I did a spine fellowship. And so, I spent 7 years there, and then, I had the opportunity to work with the likes of Ben Carson, who a lot of people know in the media, but he was one of the professors there. But there were also 21 other neurosurgery professors. So a lot of good training. I went there. I left Stanford specifically to go to Johns Hopkins because I knew the training program was really good, and I feel very, blessed that I had that opportunity and was able to kind of come back to Orange County and come home and kind of share my experiences with the community here. So, that's my story. My residency was in neurosurgery. My fellowship was in spine surgery, so I do a lot more spine. 95% of my practice is spine. I only do brains usually for emergencies. So when people see me, they really are seeing a true spine specialist. So I guess, again, we'll kind of go through my slides pretty quickly going from here on out, and then we'll reserve the rest of the time for some questions, and we'll try to answer as many as we can. So just in general, everyone and their mother has back pain. I mean, my practice is super busy. I'm probably one of the busiest guys. And I just have so many patients. And the reason being is pain drives patients to the clinic. And a lot of people have back pain or neck pain. Those are both related to the spine. And then a lot of people have nerve pain. And that's often termed sciatic pain, which goes down the legs, or pain down the arms. So those are all kind of symptoms of nerve pain or nerve compression in the spine. It's very painful. People feel like they're getting stabbed in their legs or in their arms with a knife. It's really, really painful. Same with back pain. Okay, and back pain in the middle of the back or the middle of the neck is usually caused by arthritis. This is just an example of, as our generation starts to age, we start to lean forward, and that's kind of part of the problem with the spine is, spinal posture is very important. And here in this case, someone's looking at a cell phone. You can kind of see that, over time, we start to lean forward, and it's probably not the best posture, and that leads to some spine degeneration. When we talk about the spine, I want to just be very clear. There are really two parts of the spine we focus on. Most of the time, people have pain in their lower back. That's very common. People always complain about that. That's a lumbar spine. And then other times, people have pain in their neck, and that's a cervical spine. The pain, people don't usually have too much pain in the mid back. That's a thoracic spine, and the main reason is because the thoracic spine doesn't move. It's fixed by the rib cage. So the parts that break down, just like our knees and our hips, they break down because the joint with all the movement that we have throughout our lives, the joint breaks down. The same applies to the spine. The neck and the lower back both have movement, and that's why they break down. So what does that breakdown look like? Well, here's an example of MRI. This is a common scan we get on patients who come into our clinic. And I'm going to just teach you guys what I'm looking at. And so this is a side view, looking at someone from their side. And you can see these squares. I don't know if you can see my mouse or not, but regardless, these squares are the bones of the spine, the vertebral bodies. In between these squares are the discs. And you can see the discs here are kind of whitish in color, or gray-white. And then you can see the discs at the bottom here. These are the cushions of the spine. These are broken down, and you can tell because they're not as tall as the ones above, but more so they're starting to get a little bit more dark. So on an MRI, the disc water content is white. If it's a lot of water, it's white and it's healthy. If the discs are starting to break down, you can see that they're turning a little dark, and you can see them starting to bulge right here. And behind the spinal column is a spinal cord. And so the discs oftentimes will bulge towards the spinal cord and cause nerve compression. So again, the back pain is usually caused by the collapsed discs. They're like kind of like you're riding on flat tires, and the bones can start to hit each other. And then if you have pain in your legs when it comes from the lower back, it's because the disc itself start to bulge and push on the nerves in the spinal canal. Again, another example of an MRI. And again, this is whenever someone says, hey, what scans do I need when I see a spine surgeon, or just to get evaluation in the back? It's not actually x-rays. People always get x-rays, but they're pretty rudimentary. They don't really show very much information. A CT scan shows bones, but they don't show the soft tissue. The MRI is where the money's at. MRI shows, as you can see here, the discs in between the vertebral bodies. And they can also show the spinal canal filled with the spinal nerves, which are gray, and the white is spinal fluid, which is just space. So again, the MRI is, if you ever say, hey, what images do I need? It's actually MRI for both the neck and the lower back. This is an example of, sports related injuries. People always think of, people who get disc herniations are usually young athletes who lift too much. And that is true. Here's an example. This red piece right here is of a disc that's bulging and hitting the nerve root, which is yellow. But more commonly, what I deal with in the most part are patients in their 60s or 50s, 60s, 70s, 80s who have spinal degeneration. They don't actually have a specific athletic injury, although, maybe when you were younger, in your 20s and 30s, you're athletic, and now it's catching up to you. And that's more spinal degeneration. Another classic thing we see are fractures. And again, this is an example of when someone is young. A lot of times they're in gymnasts or other athletes, they'll get a little called the Parse Fracture. A lot of you might have heard of that. It's also termed slip disc. And so in those cases, a lot of people, they get a fracture when they're younger and they feel fine. And they say, their back hurts for a few days, but then it catches up to them. And when they're in their 50s or 60s or 70s, they start to have a slip disc and a lot more degeneration. And that's because their injury caught up to them when they're older. Just this last week, I had a surfing accident. And this is an example in the neck. When people have neck injuries, surfing accidents, bicycles, motorcycles, you see quadriplegics. It's because they have a neck fracture. Now, this is not very common. What I see mostly in my clinic are people who have usually, disc herniations or spinal degeneration, but I'm just kind of going through everything. In the neck, you can also have whiplash fractures. And this is what you see in car accidents. So sometimes people say, hey, Dr. Liauw, I had a car accident when I was younger. Could that have caused what I'm feeling today as far as neck pain, arm pain, lower back pain? And yes, absolutely. You can actually, if you had an accident in the past, you could have accelerated the degeneration because you can tear some ligaments and it catches up to you 10, 20 years later. So very simply, when people see me in the clinic, they go, what is the cause of my back pain? And when people see me in my clinic, I actually try to teach them as much as I can. I go through the MRIs or their scans with them and kind of explain what I'm thinking. But really, it's very important. There's so much, so you'll read on the internet, there's so many terms for the spine. There's so many terms for back pain. It gets very confusing. So really, the way I explain to my patients and the way I even view it, it's actually very simple. There are really three causes of pain in the spine or the back or the legs. And the three causes are pain itself in the center of the back or the center of the neck is from arthritis, from the bones and the joints. If pain is shooting down the arms or shooting down the legs, that's nerve pain, okay? And so most commonly, it's either bones and joints, it's either your joints in your spine or the nerves that are the cause of pain. And if it's the joints, it's the center of the back. If it's the nerves, it's the pain that radiates outward down your arms and down your legs, into your hands, into your feet. The last cause is fatigue. A lot of people have muscle fatigue in their back, and that's just pain that kind of builds up. If they walk, they can't walk for very long distances. They start to feel fatigue in their back. That's muscle pain. Okay, so, and that's often due to bad posture. So these are the three causes of pain in the back, and pretty much this is universal. Again, this is a very blurry picture of arthritis, but you can see in this pictogram, here's a healthy disc. The disc is starting to collapse in the second one here. And if you see my mouse at the bottom, the disc is completely gone. And then people talk about, oh, I have bone spurs in my back. Well, a bone spur really is just the bones are hitting each other. And then you develop arthritic changes, and the disc will oftentimes ossify or turn into bone. So that's what a bone spur is. So non-operative treatments, we usually recommend first, and we usually try to start with non-operative treatments before we proceed with surgery. And I firmly believe that when patients come to see me, they usually just want to get an opinion on their back. They want to get it. They want to talk to me about their and see their images. And then they ask me, what would you recommend? And they look at me to kind of help quarterback some of their care. And a lot of times I don't recommend surgery. A surgeon usually shouldn't recommend surgery right off the bat. We usually recommend non-operative treatments, including epidurals, which is you can see here, where they inject into the joints of the spine. The other thing is massages. You can do acupuncture. You can use medications. You can do chiropractic, although I usually don't recommend chiropractic for the neck. I usually just say just the lower back. Sometimes I've seen people get hurt with chiropractic in the neck. And then there's a lot of, and so who does these injections? It's actually not usually the surgeons. It's usually the pain management doctor. So I'll usually put a referral for pain management. The other thing you can do is try to build up your core with yoga or physical therapy. So again, there's just a lot of things we always try to do to avoid surgery. We should, and that is the thing is I have a good problem. I have so many patients, I have so many surgeries to do that I'm actually not really looking to do surgery on patients. I actually try to keep them away from surgery unless absolutely necessary. And people know that I'm relatively very, very, I guess, candid about patient care. I usually just tell them what I'm thinking. And I'm also very honest in the sense that I usually really try not to push patients towards surgery unless it's super, super clear that they're going to get better with surgery. Just like I would do for my own mom, my own dad, or anyone in my family. This picture is just to kind of show there are some newer things that are coming out in spine. And so people say, have spine surgery advanced? Absolutely. In the last 20 years, spine surgery is actually a lot better than it looked like 20 years ago. Now we have artificial discs now that we offer in private practice. And this came from Europe, where we try not to fuse patients. Now, usually this is reserved for younger patients in their 30s or 20s or 40s. But there are motion preserving things you see with Tiger Woods and stuff like that. There are new procedures, let's just say. And, obviously there are indications for doing them or doing a fusion. But, just so people know that there are some technological advances that are significant in spine, the technique has gotten better. Again, here's an artificial disc in the neck that we often will do. I just did one today. And it's again for motion preservation, so we don't lock up the neck or the lower back unless we have to. Sometimes when people have bad arthritis, we do need to do a fusion, and this is the most common surgery. Either the two most common surgeries in spine are a nerve root decompression, which is called a laminectomy, or a fusion. And a fusion is meant to hold joints still. If there's an arthritic joint causing a lot of back pain, you hold it still. And that eliminates the arthritic wear and tear and arthritic wearing down. And that's what makes people's pain better if that is the true cause. Again, it's very important to find what is a cause. So as you can see here on the left, I say, the cause of a lot of people's pain is bone and joint wear and tear. So that's when you do a fusion. But if it's a nerve, like as you can see here, where the nerve is being pinched here on the right, we decompress. We shave this lamina behind the nerve to decompress the nerve. So again, another very common term people hear about in their MRI reports is spinal stenosis. Spinal stenosis, all it means is a pinch of the nerve. And it's usually from a buildup of arthritis that starts to push on the nerve, and that can cause sciatic pain. Which, and again, I'm just kind of teaching you guys the lingo, let's just say. Sciatic pain is pain shooting down the leg as a result of nerve pinches, which is spinal stenosis. You don't need to know myelopathy. You don't need to know claudication. All you need to know is when the spinal canal is pinched, sometimes you can have imbalance. So people a lot of times don't realize people are falling a lot. Well, a lot of times that's because their spinal cord is pinched, and people don't realize that. Another thing, a very common complaint I get from patients is that they say, hey, I actually, I can only walk a couple blocks. If after I walk a block, I have to sit down and my legs just feel tired. That's actually very common when the spinal cord is pinched. So that's called a symptom called claudication. So these are the things I pay attention to when people tell me their stories in my clinic. This is a picture, as you can see in the red highlights, of different distributions of nerves. Nerves are very complicated, and they have different distributions. So so when people say, hey, Dr. Liauw, I have pain, I go, well, where is your pain? They go, is it in the center of your back? Is it going down your thighs? Is it going down the side of your leg? Or is it going down to your ankles or your feet? And that will kind of tell me which nerve exactly is pinched. So it's those are the kind of things I pay attention to. And then I look at the MRI to see if there's a corresponding pinch in one of those nerves. Same thing with the arm. A lot of times people have shoulder pain. They always think it's their shoulder. It's actually a lot of times not their shoulder. It's oftentimes a pinch in their neck causing shoulder pain, numbness and tingling in the arms, hand weakness or numbness and tingling, or hand pain. Where they're dropping things too. This is to me, the most accurate picture of what a nerve pinch in the neck looks like. You can have pain as highlighted in red into the shoulder with a C5 compression, with a C6 compression. You can have pain that goes to the thumb. C7, you have pain that goes to the middle finger. C8, you have pain that goes to the pinky. So as you can just see, this is just kind of how we analyze which nerve is pinched, and just the pain distribution. Again, correspond that to the MRI. Here's just a 3D rendition of injections. So say a lot of times people have a disc herniation here. We will oftentimes inject anti-inflammatory steroids. And again, this is done by pain management. And they just inject it to bathe the nerves so that the pain goes down. And that's the principles of non-operative epidural injections. So a lot of times people say, hey, do you do microsurgery, minimally invasive? I do. And this is what it looks like. It's actually, we use a little tube. So it's almost like a laparoscopic procedure. And this is specifically not for back pain per se. Again, when I ask patients, where's your pain? They say back, and I go, where? They go, oh, it's actually the butt on the side of my back. And that's actually nerve pain. That's actually not midline back pain. And if that's the case, that's from a nerve pinch. So this is a picture of using a little tube going down to remove a herniated disc causing a nerve pinch. And this is our classic minimally invasive microscopic surgery, which we do day in and day out. People also need to pay attention to the muscles of the back. There's a lot of strap muscles in the back that hold us up. So it's very important. I kind of just put this up because it kind of shows that our muscles can get fatigued. That's why at the end of the day, a lot of times people have pain just because of muscle pain. And also just shows that building up your core, with sit-ups, exercises, yoga, can help strengthen your back too, because there's a lot of muscles that run in parallel along your back. Almost like a crane, that's what our muscles do. They hold us up. So, this is talking about posture. I really won't get into that other than people have poor posture, and that a lot of times is the cause of their back pain. Some of the newer modalities in surgery is we really pay attention to posture, and we see if we can correct posture these days. And then if none of those corrections work, or let's just say people occasionally you'll have patients who have back pain who are, number one, are not good surgical candidates because of their health, or number two, if you look at MRI, there's not really that much that stands out. Their backs actually look pretty good, but they're still saying there's a lot of back pain. Then we have newer technologies like spinal cord stimulators that we use, which are electronic methods to reduce pain. They're like pacemakers. And this usually I reserve as a last resort, but it is a good option for a less invasive surgery in people who don't have back problems. So I'm just ending here.